paper is about diaphragm pacing. It's entitled Further Analysis of the Diaphragm Pacing in ALS Patients with Chronic Hypoventilation, and the paper will be given by Dr. Jonathan Katz.
Thank you for having me. A couple of disclosures before I start. And these disclosures will probably be pertinent as I go through the talk, but I'm the co-PI of a randomized controlled trial on DPS right now, and I will conclude at the end of this talk that a randomized trial is needed to answer the question, so I'm going to give you a teaser. And I'm the head of the publication committee, and I will also conclude that we probably need to publish a paper on this topic. So just a background to remind you of what happened with the diaphragm pacing system originally. There was a study between 2005 and 2009 where a group which we were part of compared forced vital capacity decline during a 3-month leading period to a subsequent 9-month period after to see if diaphragm pacing would change the slope of the decline in forced vital capacity. There were 106 patients who underwent the procedure, and the inclusion criteria was they had to have a forced vital capacity between 45 and 85% at the time of the procedure. But before the study started, there was a fear that if patients were put on NIV during the course of the study, it would be a confounding factor. And it turned out in the power estimates that 30% of the enrollees were thought to start NIV, but probably between 2005 and 2009, there was sort of a change of tone in the way NIV was initiated in general in clinics. More patients went on, and the actual number in the study ended up being 75%. And many patients showed no decline during that 3-month lead-in. So it turned out that there wasn't a proper analysis at the end, and no conclusions were reached with respect to the original intent of the study. So after the study was completed, as you all know, the U.S. Food and Drug Administration granted a humanitarian device exemption. This is a way that the FDA can approve a device, but 4,000 patients per year have to, no more than 4,000 patients per year in the U.S. can come down with the disease for that device to be approved. ALS affects more than 4,000 new cases per year in the U.S., so the device was only designated for patients with ALS that met specific criteria for hypoventilation. And what happened there was that left us with, before I go on, so who is able to do this? It's more or less the same patients that can get NIV under Medicare criteria. So it's patients with chronic hypoventilation, which would mean a MIP below 60%. Or an FVC below 50. There's other criteria, but for all intents and purposes, we don't use them to start treatment. There has to be some evidence that the diaphragm could be stimulated, and that could be by fluoroscopy or by having evocable responses by phrenic stimulation. And then the FVC has to be in a range where it's not too good and not too bad, so it has to be above 45%, but less than 85%. Again, for practical purposes, if I define an FVC below 50% as being necessary to prove there's hypoventilation, and I say it can't be below 45%, because then it'll be too low to do the procedure, it leaves a very narrow window for FVC. So going forward, for all intents and purposes, patients are going to be eligible for receiving a diaphragm pacing system if their MIP is below 60% of predicted. So now we're left, I keep going backwards, I'm sorry, but now we're left with the problem when the study was over that the FVC had approved this procedure, but once it became available to clinicians and to patients, how do we know whether we should give it? So what we have here is a large uncontrolled data set and no placebo group. We have a procedure that's approved for a specified group of patients with ALS, which is even more narrow than the group that had originally been studied. We have a set of interested patients and providers who need some direction, and we have a desire to publish the data. So we have to ask the question, how do you at least come up with a guess whether this procedure is valuable, whether we should go forward, what we could do? So what we said was, can we find an appropriate database to compare these patients to? And if we were able to find an adequate database, we could say that DPS works if we can show that The survival is improved in the group that receives DPS compared to the patients in the other databases. And we have to reasonably be able to show that the populations in the databases that we choose are similar to the DPS patients. So I would have to get you all to believe both of those things to say DPS is clearly effective. So what do we choose for our database cohorts? One was a placebo group from the minocycline trial that was done between 2003 and 2005 that we've worked with before. There were 206 placebo patients in this database, and that study, this is important, required a baseline FVC of 75% and an onset of less than 3 years, just like many studies to enroll in the trial. It's just a regular drug study. So we also wanted to compare this to the diaphragm pacing system group. So 92 of these 206 patients had an FVC between 45% and 85% at 3 months post-enrollment. Enrollment spelled using the British enrollment, not the American enrollment. But it's, so again, the diaphragm pace you had to be between 45 and 85 at the time you had surgery, which was 3 months in. So we took these patients 3 months in and said you have to be booked between 45 and 85. We thought the advantages to using this group was a large database, and there was a lot of serial measurements recorded over the 12 months the patients were in the study, and there was survival data, which we were able to collect for a long time. And again, this study had a 3-month lead-in. We also compared it, to give this some more context, to a second. We could compare it to as many groups as we want because there's no right answer. We're just trying to show everybody how this group of DPS patients looks in context. So we also used the second comparison cohort, which we call the Lexin NIV study. And Noah Lexin from Johns Hopkins did a survival analysis in 92 patients who began NIV. He was actually interested in comparing patients who got NIV early when the forced vital capacity was 85 or above to patients who got it, quote unquote, late when the FVC was below that. But all the patients in that study got NIV for clinical indications such as dyspnea, orthopnea, fatigue, or sleep disturbance. The study was done in 1998 to 2005. 50 patients in that study had an FVC below 45 and 85 at initiation and less than 3 years of onset. So we could get this common criteria to put patients from every study together. The advantage of using this cohort is that they had a respiratory indication for starting therapy, which is similar to, not the same exact respiratory indication, but DPS in a sense is also a respiratory indication, and they had a survival endpoint. So this is just a summary of what I just told you, but it's a reminder that what we were interested in studying is, over here on the left, is the 86 patients who had been enrolled in the, of the 106 that started, 86 of them would have met the subsequent HDE criteria. So what we're really interested in is going forward, and there was only 86 of those 106. Some of those patients had an FVC that was too high and a MIP that was too high. They wouldn't have qualified for the study. So what we ended up with was 48 patients with DPS that had onset less than 3 years, 92 patients from the Minnow study, and 51 patients from the Lexin study. And what we went ahead and did is compare survival in these groups. So are the groups the same? So I'm going to show you a slide with a lot of data after this. It'll be hard to read, so I'm just going to summarize what you're about to see. So the groups in baseline comparisons, if we enroll the same groups, they should have similar baseline comparisons. So some things that are good predictors of outcome in ALS were similar. Their age of onset when they enrolled were similar. Their time from onset to diagnosis was similar. Their ALS FRS pre-slope, which we define as 48 minus the baseline FRS divided by the time since onset, was similar. The observed rates of FRS decline in the Minnow study and the DPS study, both patients were observed for 12 months. They declined FRS-wise at the same rate between the two studies, and their genders were similar. What was different between them was the minocycline group ended up being enrolled earlier. As you can imagine, this was a clinical trial. The patients get in much earlier than patients with respiratory indications. The Minnow group had a higher baseline FRS and FVC, which probably indicates that they got into the study earlier, so their baseline scores were higher. They had faster respiratory decline, and I'll talk about that later over the 12 months they were observed, and they used a little bit less riluzole. So here's the slide just showing this, and I'll also point out that the NIV use in the minocycline group is only 39%, but that makes sense also. These are people that are earlier in their disease than the patients who have respiratory indications. If you had followed the minocycline group out a few more years, they would have all got NIV. The onset to enrollment was 11 months in the minnow versus 24 months in the NIV. So even though we limited these patients to less than 3 years since onset, the HDE patients, which are the DPS patients, were much closer to that 3-year cutoff. They were getting it much later. The minnow patients were coming in at about 11 months after the disease started. And then, like I told you already, their baseline scores in the minnow group were higher and lower in the DPS group and in the middle in the Lexin group. So what we did is we looked at overall survival of the course of the whole disease from onset until death. And that makes sense because if a procedure is given early, the amount of time after the procedure would be longer, even if they live the same amount. If a procedure is effective, the course of the whole disease should be lengthened. So when you look at this, the way we did this analysis, the DPS group lived 39 months roughly from onset, the Lexin group 32.5, and the minnow group 31.2. And from diagnosis, the differences were even greater. 33.5 from the DPS group, to 22 for the Lexin group, and 18.2 for the minnow group. And then the DPS HDE group, just for the sake of discussion, lived 16.3 months on average from the time they had the procedure. And these are the Kaplan-Meier curves showing the same thing, which I'll just let you look at instead of repeating for a while. The DPS group is the one on the right in the blue, and the minnow group and the Lexin group lived roughly the same amount of time overall. And this is the time since onset, with the DPS group, again, doing better than the other two groups. So at this point, I just want to talk a little bit about, are the groups the same, a bit more in a few more slides. So when we consider the comparison between the DPS group and the Lexin group, we have to consider a couple of things. The DPS cohort required a stimulatable diaphragm as part of the criteria. So in other words, you have to go in and prove that at least to some degree the diaphragm works. If you take a group of patients getting NIV, they may have early symptoms already, and there's no proof that all of those patients have diaphragms that still function. We don't know what the magnitude of this requirement is on the overall outcome. And then a similar baseline FVC value might not mean the same respiratory function, so it's possible that there were different upper and lower motor neuron involvement, different amounts of bulbar dysfunction, etc. And then the appearance of the patient might have influenced decisions about the surgery. So if you have two patients with similar FVCs, wouldn't you pick the one who looks able to have surgery and not the one who doesn't? So these are all things that need to be considered. And then there's an effect on the time to enrollment. Remember I showed you earlier the minnow patients started earlier, and I just think it's worth pointing out that if I take patients who are very early in the course of their disease and compare them to a group of patients that's very late in the course of the disease, even if I could show you that they have similarities in their baseline onset and the rate that they were progressing before the disease, the problem I have is that the early group has patients who passed away in it that aren't represented in the later group, so their mean declines are probably going to be greater. What I really want to be able to do, boy, I'm having a hard time with this, so again, these are patients that passed away. What I really like to be able to do, which I'm not able to do, is ensure that I'm comparing the same patients from the early group to the ones in the late group in this type of analysis. So when we look closely at these declines, if you look at the very beginning of the Kaplan-Meier curves, there's a big drop-off in the minnow group right at the beginning, probably representing that a lot of these, that subset of patients that died in that interim. It's one possibility or way to interpret this. Then the other requirement to look at is that the minnow group required an FVC of greater than 75% at onset. So on the one hand, that's going to exclude, because remember, you have to have an FVC 3 months into this, still greater than 45. So a very rapidly progressive patient who enrolls with an FVC greater than 75 and falls all the way through the window to below 45 is going to be excluded. So the minnow is not going to have extremely sick patients in that cohort. So you're going to take out the fastest progressors, which is going to favor the minnow group against the DPS group. But there's a problem with that type of analysis too, which is active respiratory decliners could still fall from 75 to say 46 over the 3-month lead-in. And these patients obviously have very bad disease and would be included in the minnow group. I don't think there's an opportunity for as much fall in the DPS group. So again, this would probably favor that group as well. Now, one thing I did want to say is, as I looked at the data, and I just want to point this out, it's my last slide before the conclusion, but if you look here at the green curve furthest to the right, that is we just split out the longest survivors in the 36-month group from the DPS cohort. And I just want to point out that DPS does have a very large number of patients, or a seemingly large number of patients, that survive after the procedure for 40 months. So this actually represents 40 months of the patients. So if you go to 50% as the cutoff, roughly 20% of the patients survived 40 months after the procedure, which is 3 years after a procedure where they were 20 months into it. So there is this tantalizing indication that maybe there is a subset of patients that benefited from this procedure. So how do you conclude at the end of the data? I think we were able to find that DPS patients had a better outcome than the other 2 cohorts, but we could not meet the criteria that the groups are identical. I think there's, as best as we could do, there's serious issues with this type of analysis. The potential benefit, especially in the last slide that I showed you, does suggest a further evaluation of this procedure is indicated. I believe that anyway. And a randomized controlled trial is probably the best way at this point to help determine the benefit and specifically to determine who these long survivors might be and if they're different from another placebo group. Maybe the same long survivors would be in there if we select patients the same way. And then last, I think we need to consider bigger data projects to compile different types of outcome data. I mean, the PROACT database came out, which is research studies, but one of the things we found in this type of analysis is we don't really have a very good understanding of the outcomes of patients very late in their disease, and that's something that I think would be a good endeavor for the field. And then just quickly to thank Nick Margakis, Kevin Boyle, and Noah Lexner, who's on our manuscript team, and Dan Moore, who's our statistician, Dr. Miller, who's helped me with the project, the Synapse company has been fantastic when we had questions, and Ray Anders, who's the kind of grandfather of all of this. But thank you all very much for listening, and I'm happy to answer any questions.
Dr. Katz, one question before we get one from the audience. For those who are not familiar with diaphragm pacing, could you just say a word of explanation about that?
Yeah, I hope I didn't jump over that. So diaphragm pacing is a procedure where, just like it sounds, the diaphragm is paced through bilateral stimulation of the diaphragm through a procedure where electrodes are hooked up to the diaphragm and a machine that stimulates the diaphragm. And it either works as a direct effect from pacing or by exercising the diaphragm muscle.
One question that I have, you indicated that you could not analyze the change in the decline of forced vital capacity because there was no decline. But isn't that noteworthy that there was no decline in vital capacity? Were you able to analyze that between the 3 groups, the changes in pulmonary function that followed the procedure?
Well, so I may have spoke too fast, but the issue with no analysis because there was no decline was that in that first 3-month lead-in period, more patients showed no decline than had been expected in their forced vital capacity over those 3 months. So if your lead-in period has no decline, it becomes very hard to get a fair analysis of your subsequent 9-month period.
Do you have ALS-FRS data on these patients?
In the minnow group and the diaphragm pacing group, we showed the data, yes.
On the decline of ALS, you showed us the baseline.
So over the 12 months that those 2 groups were observed, the declines were similar between the 2 groups. They were almost identical.
Are there any other questions? So the randomized controlled trial is underway. Could you tell us how far along that is and what the goal is?
So the randomized controlled trial is, our goal is to enroll 180 patients, 120 treatment and 60 placebo, and we've enrolled 40 patients so far. It's to implant 180 patients. We've enrolled 40 and implanted about 30 something at this
How
point.
many sites?
There's 20 sites.
I thank you very much.
Okay.